Good afternoon to all. We welcome you all to today's PIPS Echo session. So I'm glad to introduce Dr. Vidhya as a palliative care physician. So she is a national faculty of Indian Association of Palliative Care, and she is a volunteer palliative care physician at St. Joseph Hospice at Andhra Pradesh. Currently, she is a assistant professor in palliative care department at Homi Baba Cancer Hospital and Research Center. I welcome you, ma'am, to take out this session.
Thank you very much, Shiva. Nice to see you, Dr. Sunil, and very nice initiative to start this foundation course for doctors. It's very heartening to see them from all over. Today, I'd just like to take you through over the next about 20 minutes or so through, because Shiva, that's the time, right? About 20 minutes is okay?
Yes.
Yeah. So in this about communication in palliative care. Communication in medicine itself is a very important part of it. And in palliative care, it gains a lot of importance. So I'd just like to take through the first video. Dr. Rajgopal will be again taking one more session on the deeper aspects of communication.
Madam, your voice is not clear. Madam?
Sorry?
Please move to the mic. Yeah.
Is this mic is not moving?
It's working, but the voice is not loud.
Okay. Next slide. So what does communication mean? Is this better, Dr. Sunil? Okay. So, and what are the tools that we need? When we talk of communication in palliative medicine or in any doctor-patient relationship, what we understand is that it's a two-way process. It's more of a dialogue. It's not like a monologue. And two things are paramount. One is you should want to have that communication. So the basic human quality of courtesy, compassion, empathy, understanding is very important. And just having the quality without having the skills will not help. So we need to have the skills in communication as well as understanding that this is an important conversation that I'm going to have. This is the first part of good communication. And why do we need it? Why is it that with all our medicine, we still need good communication? Because from the patient's perspective, he or she comes to us with a huge amount of anxiety. So what they need is guidance, and what they need is an exchange of what ideas, what they feel. The family has to be involved, and they should not be felt as if they are completely left out. And over a period of time, good communication always helps in improving acceptance, in improving trust. Because even in the course of treatment, we have realized that if we communicate well to the patient, the compliance in taking treatment is way better because they understand why they are going through all that. So all these could be or are the benefits of good communication. And we keep using this word, counseling. We keep using it very often. We say patient needs counseling. So what exactly do we mean by counseling? If we talk of counseling, it's more like an exchange. It is not what I can do for the patient. It is more like a guidance. Because when they come to us with problems, when they have multiple issues, and especially in palliative care, when disease prognosis is changing, when decisions have to be made about taking chemotherapy, not taking chemotherapy, if the patient has cancer, about going in for dialysis, about going in for transplant, and about the symptom burden, we have so many issues to deal with. So in each of these situations, we cannot provide a one-stop solution for any patient. So what is most important? What does counseling mean? It helps us to convey to the patient what is the problem. The patient, it gives an opportunity for the patient to talk to us and tell us what he feels and how he is going to come to terms. And what we are trying to do is trying to provide a guideline, trying to provide a path. So all this will now help him to make his choice. We are not going to make that choice for him. The choice, the decision is always made by the patient. But for him to come to that decision, we need to guide him through. And that is what we essentially mean by counseling. So when we say that that this is an autonomous decision, patient does not want this treatment. What is most important is, has he or she understood what it actually is? And only then come to that decision. So for helping the patient understand, counseling is important. And from the doctor's perspective, it's not providing the solution, but it is just guiding them to make their own decision. And when we say counseling, we now empower the patient. After a counseling session, the patient has to become empowered. He has to feel that, yes, I can cope with this. This is what I have as treatment options. This is what I need to choose. I can choose whether I want to be in a hospice, whether I want to be at home, whether I can follow up in the OPD. I can choose. The family is now aware that they have these choices and they can all talk to each other. So if you have counseled the patient well, all these would necessarily be the outcomes of counseling. But having said that, and we realize how important it is, but still, are we able to do it? As doctors, as professionals, we were never trained in this. We spent our time in medical school learning about all kinds of medications, when 80% of the time we are actually talking to patients, but were we ever taught? We were never taught communication skills when we were students. So when we have not been taught, I think it's more important for each one of us to train, because with so many benefits of good counseling, we should know. So what are the barriers that we see? Where do we falter? What are our problems? As professionals, what are the difficulties we face? The first roadblock comes when you don't have a treatment option, when you can't cure the patient. You can't offer anything that your books have told you. So would you like to say, I'm sorry, but I do not have any treatment with me? We were never taught, we were never trained to say that. So we find it very difficult. We do not know how to communicate that to the patient. And no one likes to make another person unhappy. So you don't want to upset your patient. You don't want to tell him that this is not there for you. We do not have a treatment for you. And the most important part, as doctors, we do not know how to handle the patient's reactions. If he gets angry, if he gets upset, what are we supposed to do? Because we are human beings, we are doctors, but how do we cope with all this? So what do? We take the easy route. Taking the easy route means, yes, do you have pain? I will address it. Do you have this? I will address it. So we focus on the physical and we completely shut ourselves out from communicating, and we stop looking at the bigger picture. We only look at the smaller picture. Okay, what is your problem right now? Let me try and handle that. But what is the bigger picture? We always stay away from, because we ourselves are not prepared or trained to do it. And when we look at the patient's side, what are his difficulties, his or her difficulties? One huge factor in the Indian context is time. We see so many patients a day that most of the time we really do not have the time to sit and talk across to them. Second is privacy. In an OPD, you have multiple patients. You have so many people walking in and out of your clinic. You have relatives around you. So how are you going to manage? Third thing is, how comfortable is a patient telling a doctor about things like psychosocial issues or emotional issues? How often do you have a patient sharing it with you without having asked the patient that? So in all this, even today, sometimes you look at the doctor as somebody who can only cure you. You do not feel that this is a person I can talk to. So from the patient's side, we have these kind of barriers. From the doctor's side, we have our own barriers. So and what are the other barriers that we have? We have a lot of interruptions. We all focus on the easy things that we can do because communicating and conveying these things is not easy. Then we start getting judgmental, we start becoming angry. We say, why did you smoke when a patient comes to you with cancer, instead of now starting to find out a way for him? Then otherwise we say, oh, this is so sad. And we stop there. And we use a lot of medical words. All these can be huge barriers to effective communication. None of this is going to help that relationship, which is based on trust. And then we always have these difficult questions. What are these difficult questions? What do they do to you? They can be emotionally overwhelming. There is something hidden which we do not want to face. We do not want to give them the bad news. Most importantly, many a times we do not know. How do you know what is going to happen to this person or patient? Most of the time we do not know the prognosis. We have inadequate information. We are not sure of the outcome. And this is because we didn't anticipate it. We do not know the answer. We are unsure of our own capacity to handle it. And fresh out of medical school, how do you expect a young doctor to do all this on his own? So some of the difficult questions that we face are, the patient wants to ask you, will I become all right? Will my disease come back? What is the other treatment for my disease? How long do I have to live? But does he ever ask you all that? This is always there in the background, but never asked. It's like that big elephant that stays in the room. And these are difficult questions because there is a lot of emotion. There is a lot of finality. When the patient is actually asking you, how long do I have to live? Very often, what we do is we try and ask him, why are you asking me this question? Then immediately the answer comes from somewhere. No, there is a wedding in the family, or there is something which I'm looking forward to. Then slowly the entire conversation changes. So when we train ourselves to ask questions first, when they ask you a question, things start sorting themselves out. So how can we do this more effectively? How do we train to do this? How can we start? In our own small way, each one of us over here can start right after we go back. The first thing is we have to greet and have a proper seating arrangement, choose an appropriate place, and don't tower above the patient. This is what we were always taught. When the patient is lying down and you stand above the patient, you're looking down at him like that. You're on a completely different level. And that doesn't help. In good communication, you need to have eye contact. You need to introduce yourself. You need to tell the patient who you are and what you plan to do, and ensure that the patient is as comfortable as possible. If the patient is in visible pain, please give him medication first, settle the pain, and then try talking to him, because no one will want to talk to you when they have pain. So this is an ideal arrangement where you have a chair, where you have a table which is not a barrier. It doesn't come right in between. You sit so that you can see each other, or if the patient is lying down, sit on a stool next to them, and then introduce yourself and then start the conversation. When we start asking questions, usually what do? We say, oh, how is your pain? How are you feeling? Are you better since last time? Did the medicine I gave you work? Finished. You have closed all the barriers. So the kind of questioning that we encourage is what we call as open questions, which means, how are you feeling today? What is going on in your mind? How did you feel? So what you have done by asking a question like that is opening up the entire family and the patient. And what you'll get might even surprise you. They will not be the answers that you foresaw. So then the conversation begins. Then you start getting more information. And then you start understanding what your patient is actually feeling. Whereas the minute you have a closed question, like, are you worrying? Do you have pain? Do you eat your food? Finished. You've just closed it there. He's going to say yes. He's going to say no. And that will be the end of the story. You can't get anywhere beyond that. So the first key is train yourself to ask open questions. Each one of us can have a few questions which we have with us. And we know when the patient comes to you, we can just start by asking these questions. Over a period of time, you will develop your own style, your own way of communication. But focus on the questions being open questions and not answers like yes or no, which are closed questions. And the most important part of communication is listening, something we seldom do. We like to talk and we do not want to listen. Or even if we are listening, we are only hearing, we are not listening. So when we ask open questions, we are simplifying it for ourselves. We are now encouraging the patient to talk. So as they talk, we have begun listening. And if there are times of silence, accept it, let it be, tolerate that silence. And most importantly, keep repeating what the patient said. So that reinforces the conversation and the communication. And then prioritize what they want and summarize it. And the most important, like what we say, is our non-verbal communication and empathy. These are two areas we need to focus. Even when we talk to someone, if you're going to talk to them, when you're completely disinterested or you do not maintain eye contact, the other person is going to know. And then they just clam up. They're not going to talk to you after that. Avoid statements like, those, I'm sure you're feeling well because I gave you the medicines. Finished. You've just closed it there. The patient doesn't have the guts to tell you that, no, your medicines are not working on me. And then don't get, a lot of things which patients say may make us angry. A lot of things that we say may make them angry too. But at that time, control over our emotions is paramount. You cannot turn around and ask them, do you doubt what I'm telling you? Finished. You just closed that communication there. So some examples of what we usually use, like when we say empathic statements, it means that I can see how you are upset you are. Never say I know, because we never know what the patient is going through. So we always use the word, I understand what is happening to you. I can tell that you weren't expecting this. I'm sorry I have to tell you that. So use that little emotion. Explore, that's one word we use very, very commonly. So when we say explore, you have to say, can you explain? Can you tell me something more? Why did this frighten you? So this pain came back. So what is frightening you? 9 times out of 10, they'll tell you, oh, it reminded me of the disease when it first came. So validating responses means that yes, in your place, everyone would feel that way. So that's what we mean by a validating response. So when we say many other patients also feel like that, immediately the patient feels, oh, I'm not alone in this. So you have communicated with just one line by telling them, I understand that you feel this way. And to do all of this, it doesn't happen overnight. We need to train. So for that, we first, besides training, we also have to know what we are talking. So we need to prepare the facts. We need to have the case study. We need to understand what we are going to say. You can't just walk into a room and start communicating beautifully. You have to do your homework right. You have to set the right atmosphere. And the most important thing is the dictum of ask, tell, ask. You don't have to tell them everything. Ask them. What makes you say that? Why are you feeling like this? Why did you ask me this question? The minute you ask, there will be a response. Again, you can ask another question. So that's how it builds up the entire relationship, and you start understanding what the patient wants. And another thing is, we've never learned to say that I don't know, because we feel that we are supposed to know everything. But many a times there are things that we really do not know. When the patient asks me, how long do I have? Do I know? I don't know the answer to it most of the time. So if you can be honest, you can tell them that maybe I cannot give you the exact figures, but why are you asking me these questions? Then consult everybody. Do not be judgmental. When the patient towards the end of life, don't say that, see, this is what happens to you when you eat or drink or smoke. You didn't mean wrong, but that is not the time Like instead of saying esophagus, you can say the place where your food goes down, or your stomach, or bleeding instead of hemorrhage. Use simpler terms so that they understand. Another very common thing which we see, especially in oncology, because that's what I deal with most of the time, the oncologists usually tell the patient, oh, disease has progressed. We are not giving you chemotherapy. And can you believe it? But 9 times out of 10, the patient will come to us and with a big smile, and they'll say, doctor said no more chemotherapy. And you are wondering, you're looking at reports, you're looking at them, and now I've realized what they're trying to tell you is chemotherapy has stopped, which means I'm fine. And they told me progressed. Now, what have we learned from our perspective? What does progress mean? From childhood, we were taught progress is something good. You got a progress report. You progressed in life. So it always meant something good. But from the oncology perspective, progression of disease means bad news. So our terminology, the words we use, we have to be very, very clear. So that patient has not understood that his cancer has now increased and we are stopping chemotherapy. He has in fact got it completely the other side. He thinks that he is now doing well and he does not need chemotherapy. So the terminology we use, the way we talk to them is very, very important. We need to create a bond. Finally, we have to understand that we are not sitting on a pedestal there. So to create that bond, we need to instill trust, be there to help. And most important, none of these things can be done on your own. So work with a team. Work with a team because there are things that you will not be able to communicate, but your social worker or your nurse will be able to do it way better than you. Allow them. Maybe your counselor will do it way better than you. Allow them. There are other things that you might be able to do better. So those things you take on. And ask. You lose nothing. Consult another specialist. Speak to your colleague. So you're welcome to do all that. The minute you do that, the patients feel, oh yes, this person does have my interest in mind. And she is communicating herself or he is communicating himself, which makes you form a nice bond or a nice team to work with. The non-verbal is the most important. 7% of what we convey is through words. The rest of it is our body language, the way we speak, the intonation to our voice, the tone we use. If you're really strict, there are times you'll have to lower your tone. So your intonation, all this conveys way more than what you actually speak. So these are things that we need to focus on, we need to understand. So if you are not looking at the patient or if you're not looking at them, if you're looking onto your computer or your system and you're busy typing or you're answering your phone or speaking to somebody else, you have lost those precious 5 minutes in which you communicate with your patient. So empathy is, I know exactly how you feel. There is a lot of difference between sympathy and empathy. And empathy is one trait which we need to have as physicians, which is the capacity to recognize emotions that are felt by another person. So when we say, what are the expressions of empathy? We have a little acronym for that. We call it NURSE. So when somebody is angry with you, don't retort. Tell them, I think you're angry. I can imagine how upsetting this is. I'm happy that you've taken your chemotherapy well. I will be here. So when you do all this, automatically you are supporting your patient. And the minute someone is angry at you and you tell them, I understand that you're angry, that level of anger just comes down. The trouble is that at that point in time, unless we train ourselves to do this, we will not be able to do it. And that's why I think training in communication becomes so important. Another part of it is, I'm just touching on it because this session is really just cramping in all the little things that we have, all the things that we need to convey in communication. So there's something called bad news, which no one likes. We do not like to give bad news. Doctors don't like to give it. Patients don't like to receive it. And unfortunately, we do it almost in every consulting of ours. Every consultation, we have some bad news to convey. So how do we do that? We should understand that we cannot change the news. It is there to be given. It has to be conveyed. The goal is, how are we going to do this in a better way? So in one slide, it is just, what are the bad news conversations? The bad news is not just about a diagnosis. A lot of times we are told, bad news, someone has cancer, you're conveying it. That's not just one bad news. Bad news can be a multiple things. It could be when your option initially was cure and now you're slowly saying your cure is not an option. It could be discussing prognosis. It could be shifting goals of care. Patient would like to go home, but right now he's not going to be able to go home. So somebody is getting married in the house, but then the prognosis is so bad that they're not going to live to see that marriage. So there are so many things which can be bad news conversations. So how do we go about this? There's something called a spikes protocol that we have. So spikes means the SPIKES, which is, first prepare yourself. Don't do it on corridors. Don't do it at places where no one can even listen to you. So your setting has to be right. And then you should be well prepared. You should understand what you're going to talk. So the perception of the condition, what is this, how serious it is. Then the most important is invite the patient. Ask them, please tell me what you have understood about your reports. That will give you half the information. Once they do that, then you start by adding on to the knowledge. But do you understand now that these reports may mean this? Then that starts your communication. Yes, you can have a person breaking down. Somebody might cry. Somebody might get angry. At that point in time, you should be prepared to give them that 2 minutes of silence, that little bit of respect, give them that time so that they can explore those emotions. And finally, at the end of it, strategize and summarize. Don't cut them off and say, you don't need to come to me anymore. Leave it open. Tell them that they can come back, they can see you, and what is the plan that we have, that we are always there for you. Communications is a skill and experience. You can't say, I have been a doctor for 20 years, I know to communicate. I think that's the saddest thing that we do most of the time, and it does not happen. So unless we train, unless we understand, unless we practice, it is not something that we can do very easily. But in the Indian scenario, we have a crowded OPD. We start with relatives, reports, and half the time we are breaking bad news to anyone except the patient. It's mostly with the relatives, and patients are the last to hear. And patients' relatives will come and tell you, please don't tell him, he'll not be able to bear it. Which brings us to the last part of what we have today, which is collusion. What we mean by collusion is, please don't tell him. You can tell me, but don't tell him. So collusion is like a conspiracy. It's something which is an act of love to protect someone, but it does not work out like that. So ask the family, what are you afraid? Why don't you want to tell them? Acknowledge it. Tell them that I understand that you love your family and you must be thinking like that, but it is important that the patient understands or knows about this. Explain to them the benefits and the consequences of not turning. But many times there may be things like writing a will, finishing important work. So unless the patient knows all this, these things cannot happen. But please remember that these are not things that can happen overnight. You need to have the patient with you for a period of time. You need to understand the family dynamics, and you might not always win. But it's never wrong to negotiate. So our process starts like that. Get one foot into the door, start talking to the family, build that trust, and slowly, that is how we start communicating well with the family and breaking collusion. With that, I think I'll just finish this part of the didactic lecture. It's hard to communicate when I actually don't see most of you. I find that a huge barrier. I don't know, Dr. Sunil, if my voice was audible or what. And the barrier for me was not actually seeing you, because I find that very difficult to do when I communicate, when I take a communications class. And we usually do these things with role play, so which makes it way more interesting when you have a couple of people demonstrating a particular scenario. Now I'd like to just throw it open to any one of you for any questions or case discussion as the palliative care secco session would like to take it on. Thank you, Dr. Sunil. Welcome, any questions.
Can you stop sharing the screen? Yeah, thank you. So, anybody want to ask any questions?
How many of you actually feel that communication should be taught to you when you're training? In because I can see a lot of young faces out there. So, how much of communication did you actually learn when you were training, and how much of it do you feel is important to learn? I mean, in retrospect, do you feel that it's necessary?
Yes, ma'am.
Yes, ma'am.
It was needed for us because most of the times we are lacking how to break a bad news. Like we tend to break it in a different way, so it'll create a problem in the family or with the patient. They can't handle it. So this would be helpful for us when we talk to the patient and further. But ma'am, I just have one question. The thing is, when we try to talk to the patient, sometimes when we empathize them, they get closer. How to handle that gap between, because we need to even maintain the distance, right? Sometimes how to handle it, because I'm not sure about it.
That's actually a very nice question, because it's something that we feel that as doctors you can't cross a particular line. I completely agree. We need to maintain that professional distance. So that is where, especially in fields where we deal with chronic diseases and in palliative care, we always work with a team. So when we have a team, there is a social worker, there is a psychologist, or there is a nurse or somebody. There is always a little team with you. So there are certain things which they may be more comfortable talking to them. And if you personally feel uncomfortable talking to them when they have expressed something to you, then you gently say, yes, I completely understand that this is what you're going through. And then, slowly divert it to your nurse or your social worker. But don't put a barrier, don't close off and say, these are not things that you're supposed to discuss with me. It has to be gentle, because you finally understand that that person there is another human being and you also are a human being. So the one solution to this is working with a team or working with someone else, because taking everything on ourselves can be huge even for us. And it becomes important even from the self-care perspective. Having said that, I also agree that we do not have the resources, that we all have the joy of working in team. We do have barriers to that. We are small, we may be just a one team person or a one person in an OPD. So try and share it with someone else at that point in time. Tell that patient, I understand what you're going through. The minute you do that, that's all they want to hear. That you have heard them, which is very important. They don't want you to provide a solution all the time.
Ma'am, one more doubt, ma'am. As you said, a teamwork would be good, but in team, the patient might be comfortable with one person, like a psychologist. Few things they might reveal it to them, but a few things we might not know it. But in our discussion, because we are working as a team, we will separately discuss and then we'll again talk to patient. Will that cause again will the patient be upset when we try to acknowledge that we came to know from the psychologist or something? So how to handle that kind of situations?
That's again a very nice question. So usually in our case sheet, we always have these things written. And in Kerala, if one of you would like to, any of the case sheets or any of the patients that we see in palliative care, the nurse first takes a history, the social worker takes a history. So by the time it comes to you, you are already aware. So the patient has now gone through those and come to you. So it's not a secret. It's not something that's hidden from them. So if you can start right from the beginning by gently asking, okay, so these are your issues at home, or so how is your child doing now? If you know that there is a retarded child in the family, say for example, and they have told that to the relative, you don't need to ask them, so you have a retarded child. All you need to do is say, how is your child? How are you managing? So you have put it across to them that you are aware of the family dynamics, and yet not cross that personal line by saying, how are you now looking after? What else are you doing? That is not your focus. In your conversation, you have brought it out. There is nothing wrong that to say that you know, because they understand that we are working as a team. So there is nothing hidden. And that's one more thing which is very important in communication, is the questions you ask should not be out of curiosity. It should not be directed out of curiosity. You can't say, okay, if you're taking a history about sexual activity or something like that, you can't say, okay, how many, it's your tone of questioning and the way you put across your question. So it is not a secret. It is not like you can't delve into what the psychologist has done. It is understood that all of you are working for them. So the family and the patient understand that. But the psychologist discusses more of those issues, you discuss more of the physical issues. You work as a team. And there is no harm in gently revealing to them that you know. There is really no harm. Unless the patient specifically requests that this should be kept as a secret. But that secret is in your team. It is not for one person. That's how usually teamwork goes.
Thank you so much, ma'am. Thank you.
Actually, we all have some limitations during communication, and how close we should behave with patients. And all of us have, or we should draw certain lines, and these lines will be different for all of us. Some people will be more close. Some people think that no, I can't go that up to him, and so it's all our personal choice. We should make ourselves aware that how close we should go to the patient, how close we should behave to the patient. So it's all our choice, and that varies from person to person. For example, many patients, when we see, they ask our personal phone numbers, not to all, but to some people. So that means these people are maybe they are feeling that they are very close and we can have a free communication or open communication with them. So when they ask, some people choose not to give, but some people choose to give. That's all that's your limitation. That's what you have to understand.
Oh, that's very true. And the minute you give your personal number, you start getting messages on WhatsApp, and you start getting, all that. So those are things we have to stop right in the beginning. So for your out of hours, our suggestion is that keep one neutral number or one phone, which is a simple basic phone without all these, so the patient can communicate for need, and that should be conveyed to the patient. Of course, like what Dr. Sunil said, it's entirely a personal choice, but like our patients do have that thing to take that extra advantage and immediately start sending messages and things like that. So then it becomes difficult if you once start that. So before you take that first step, you draw your line and then decide how far you want to go. So that's important thing to do.
Anybody? There are many barriers in communication. Already Dr. Vidya talked about that, but I would like to ask one question. As doctors, we wear uniforms, stethoscopes, etc., isn't it? So what do you think? Is it a barrier? What is your feeling?
I think so. That's a patient's perspective. For some patients, if they see you only if they see you with stethoscope and a white coat, then they're happy. They know that they've been taken care of someone professionally. But for some people, they prefer seeing you as a person first, then as the doctor. So I think that is also patient person. I don't think there is one formula that we can follow with everybody. Then there's a lot of there's a lot of gender discriminations in India. You have to be careful when it's a female doctor who's dealing with a male patient. He will immediately either completely close up. He won't be ready to discuss. That is one major barrier, I think. So in India, you have to be aware of that barrier also. Communication.
So maybe how ma'am told, non-verbal communication helps. So the anxiety or the way the patient expresses the the facial expressions by looking at them, maybe we can understand whether they are comfortable when we wear a stet and the coat, white coat, apron, or they might not. They're not comfortable. Maybe non-verbal communication from their end will help us, I guess. Then we can help ourselves, like talking to them.
Okay.
Dr. Manoj?
And yes, I do have a confession. I've just touched on the topics of communication. There is still a lot. Those of you who wish to do more of palliative care, I think there is a whole, there's so much in communication. So it's interesting, and if you wish to take it forward, there is a lot more to read. I've just touched on the important aspects of communication. And like what Dr. Sunil said, most of us don't wear our aprons and our stets, isn't it, Dr. Sunil? Somehow we were told, in palliative care, don't wear it. It becomes a barrier. And somehow all of us land up not wearing it. But it also helps because in the hospice, very often I tell everyone that we are all the same. Today there was a patient who came and said, that sweeper shouted at me. I said, please don't call her a sweeper. All of us work together for your patient, whether we are doctors, nurses, or helpers. So sometimes we can use that as, and then we say, we all work for you. Then they immediately kind of calm down and say, okay, that's the way it is. So I think it's again personal choice, but
Yeah.
it's nice to work without the coat and say we are all on the same boat.
And that's both pros and cons. Yeah. So while we communicate with patient, how close should we sit with the patient? Anybody? Jena?
So maybe we should start from a little far, and then depending on if the patient is comfortable, maybe. I have no idea. I don't know. That's a very gray area, I think.
Okay.
Maybe it's one hand distance, like in case you want to talk to a patient, then you can just hold the hand or some, in case if it's needed to just console the patient. So maybe that much distance would be okay.
Okay, so there is a concept called comfortable space or personal space or buffer zone, which means that each people they have a comfortable space which we should respect. When we meet somebody, if they are very close to us, we will move to them. But if they are not familiar to us, we will tend to move away from them, isn't it? So it is because that there is some person thing called personal space around us. So we all need that for comfort. So we should keep that personal space. We don't know how much it is, but if we sit with somebody, and if you see that that person is holding back like this, that means we are not respecting that personal space. Or sometimes they will move the chair a little bit like this. So all this indicate that the personal space is not correct. So we should be aware about that, because many times when maybe some people think that as a doctor we should go close to the patient and touch them. That's all. That's all are the things that is there in mind of some people. But when somebody who is not very familiar with us come and directly touch us, we also don't feel good. So we should first create some trust with the patient, and only in such situations when it is necessary to touch the patient, then only you need to touch. Otherwise, touch is not a good thing. But in situations when it warrants, it helps the patient. So that's the personal space. I think Dr. Vidya did a wonderful job, because usually these communication sessions we do it maybe in 2 days or 3 days, and she tried to give you an overview about that. So if you are interested, maybe it will be helpful for you to attend a 6 week course in palliative medicine.
It's quite nice because when you attend these courses, they make you do a lot of role plays, they give you scenarios, and that's when you're doing it in front of someone, you realize you break down your own inhibitions, because it's very important. It's easy to sit here and say, do this and do that, but when you're actually sitting in front of a patient and you're talking to them, and when you have that very limited time, which we do not have the luxury of time which they have in the West. So when we have that much time, how do we put across all of that? So that is where it will really benefit if we could do these role plays and things like that. That really helps. And communicating in children, I have not even touched on that. That's a completely different scenario. I mean, that has a lot of other issues too. So
It's very common to hear that we don't have time to communicate. So, what are your thoughts about that? So, all of you will be very busy people, and what is your answer to that?
in fact, in one of the role plays, we actually took this as a point. We said we are all busy. So now we're giving you the time to do it. And they managed to do it beautifully, and the time was just about 5 minutes. So, do we really have that excuse? Think about it.
Sometimes there may be 100 patients visiting your OPD, but all of them doesn't require a broad communication or a detailed communication. You only need to just smile and just a greeting. That will do the trick, and they will feel that okay, doctor did smile at me, he greeted me. So, and another patient, they may come and cry at you. So that then you really need to communicate with them. That will take some time. But all others need only just a smile, or that non-verbal communication. That will itself satisfy them. So I don't think there is an excuse of no time for communication.
Yeah, that's very true, because most of the patients who come in the OPD will need just that little, and some of them will take at least 15-20 minutes. So that difference that is made up in that time. So start by greeting your patients. I think that is the most important. If we just start by greeting, acknowledging, smiling, that is the first step. And have those nice little questions that you will ask them, which are open questions. These two things, I think each one of us can start in our practice, irrespective of whatever you do. You need not be doing palliative care. You can do any specialty. Greet your patient, one little smile, and most importantly, start asking open-ended questions. I think that would be the first step. And listen. If you can, just listen.
Shall we move on to the case presentation?
No, can everybody hear me? Good evening to everybody. But I cannot hear. Now, mm,
We can hear you. Please proceed.
so Siva has to call me to say me to please proceed. Anyways, good evening, ma'am, and good evening, everybody. Good evening, sir. Our case was okay. Okay, so generally speaking, collusion is defined as a secret agreement or cooperation between two or more people who are trying to deceive. In our healthcare, collusion implies to any information about the diagnosis, prognosis, and medical details about the person who is ill, which is being withheld or not shared among individuals involved. So it also means that relevant and complete medical information is selectively not disclosed or completely not disclosed to patient or relatives. Next slide, please. So collusion is not always a conspiracy of silence. It may be a conspiracy of lopsided communication as well. Means if we do not communicate completely or effectively to the patient, or we give the patient and family the incomplete information about the disease, or the family, they do not tell the patient the complete information about the disease status and prognosis, it also comes under the collusion. Next, please. Now, here is a case. A 30-year-old male, he was admitted in palliative care ward with complaints of recurrent metastatic soft tissue sarcoma with a large raw ulcer in the right inguinal region and upper thigh. There was continuous oozing from the local site, which was aggravated in between, for which transfusion had to be done for multiple times. Large vessels in the inguinal regions were exposed and were at risk of erosion at any time. So this was the presentation when the patient was referred for the end-of-life care in our palliative ward. Now the history was like this. 2 years back, he had a mass in the right upper thigh. He consulted in oncosurgery, where he was given option for either a limb salvage surgery or amputation. So he chose for limb salvage. At that time, he was a student of BA third year and was preparing for a competitive examination. Now he was very hopeful of complete cure at that time, and so he thought that he had undergone the limb salvage. Now tumor has gone completely, but it was not so. Next. After 8 months of surgery, there was a local. He again consulted his doctor, who advised him for amputation. Patient at that time was not willing to lose his limb even. He was a football player of national level. So he wanted that anyhow he retain his limb, and he decided to go for a higher center, TMC Mumbai. There he again was advised for amputation, but he denied there also and came back to Jaipur. Within 1 month, there was a local huge ulcer and spread of the disease beyond the inguinal ligament. And there was an episode of profuse bleeding from the wound, and he was rushed to hospital and admitted in the emergency. He had given multiple transfusions, treated for the disseminated intravascular coagulation, and revived. Then he was sent to our palliative ward because surgery was not possible at that time. Next. At the time of examination, he was conscious, alert, but he was very much anxious. His wound was oozing continuously, his coagulation profile was deranged, and blood pressure was fluctuating. There was foul smell coming from the wound despite of charcoal and metronidazole treatment. Next. He was having moderate to severe pain. Still, he was quite hopeful about his recovery and was insisting on amputation to remove the diseased limb. He was very agitated and anxious why he was not being transported to Mumbai from Jaipur to get operated there, and was very confident and hopeful that if that diseased limb will be removed, then he will be all right and okay. He was not able to understand, and he was not ready to hear that the disease has spread along, and now it was not possible to save the limb even and save the life even. And next. His relatives knew about the diagnosis and prognosis of the disease from the beginning till end, but the patient was aware of his illness but not fully counseled about the prognosis of the disease. He was told that he has a tumor in the limb, but he was not told that it has spread beyond the limit of cure, and now that amputation was also not possible. His relative did not want to tell him about his final disease status and prognosis, as they did not want to break his hopes. Secondly, he also was very hopeful that something like miracle will happen, and he said that I have conquered many problems in my life, so I will conquer this also, and this is a matter of few days, and with my confidence and my will, I will conquer it. He used to say that I have heard many success stories of cancer patients, and I know this is all about will. So patient was asking repeatedly to doctors whether he will be cured or not, and family was counseled to break the bad news to patient slowly, but they were not agreeing. Now next. So in this patient, at that time, he was not aware of the prognosis of his disease. So the doctors and the medical team, we tried to tell him indirectly, but at the same time, family denied it strictly. They said that we will not tell him at any cost because he is so much helpful about his life and cure that he will be shattered badly. So here in this table, we will see about the root causes of the collision. Mainly explain and update the family members about the patient's medical condition. In our case, the family, they were not, they did not want the patient to know, and hence they understand that the reasons, what the reasons were, and they show the empathy, but they were not able to tell the patient. They were saying that patient is not ready to hear, and he is talking about the cure all the time. So they said that it is better that he will die in hope, despite that they will let him die in despair and hopelessness and darkness. So this is a algorithm or a pathway how we can counsel the patients and their families. Like, we will explain and update the family members about the patient's medical condition. If the family wants to know about the patient's diagnosis, then if the clinician have to break the bad news, then we will see whether the patient is mentally competent or not. And if the patient also want to know the diagnosis, then we can communicate the bad news to the patient in the usual way. Warning short, in stages, and at doses appropriate to the patient's ability to cope, so that the patient is aware of the diagnosis. If the family wants to break the bad news by themselves, then coach the family how to break the bad news. If the family doesn't want the patient to know, or the family is undecided, then understand what are the reasons and whether they are valid or not. If they are valid, then we should show empathy towards them and ask the family if the patient has ever expressed the wish to know. Explore the family's wish if they were the patients, arouse family's empathy, and make the family understand that the reaction to bad news is naturally not good, but must not underestimate the inner reasons of the patients. So the truth hurts, but lying and giving false hope is much worse. And explain the family that there are techniques to break the bad news, and offer to do it for the family if they feel uncomfortable. And we may provide a pamphlet on the collision also. Next screen. Next, please. Yeah. Here are some reasons why the family, they do not choose to break the bad news. Because they think that the patient can lose hope. It may lead to depression. It will hasten the progression of the illness and death. They will say that he will become hopeless and depressed, and it will progress the speed of the disease. It may increase the risk of patient suicide. It may cause psychological pain to the patient. Family members themselves may not be aware of the nature and severity of the illness. Sometimes there is like the family members, they are also in complete denial. So we have to counsel them also and make them aware about the, like we say that, okay, the disease is so progressed and so severe that it is not able to save the life now. But they, at the end of the interview, they say, okay, Dr. Sahab, theek to ho jayega na. So it is all the time that they also, the family members, they also do not want to lose hope. So they are also in denial, or maybe they conflict. Next. So how to manage the collision? In our patient, we interviewed and then we counseled the family members. We called in for a family meeting, and then we asked each and every member what they think will happen to the patient if we break that bad news. So surprisingly, each and every family member had his or her own different version about this. Some say that he will not be able to cope it. Some say he will not be able to hear about it and will be very, very hopeless. Some say, no, I think he will not be, he will hear, but then he will not continue the treatment, and he will outrightly stop all the treatment. That's why we do not want to hear him. Some say he will cry. Everybody has his or her own version. So this algorithm shows the all the stakeholders involved what they can do. So medical staff, they had no definite role, but they feels that family have right to decide or defer the family's decision. They may not have time, they may not want to support. There may be language problem because the patient and their family may have come from different culture. They may be waiting for some reports to confirm the diagnosis, or simply they may pass the buck to others, like oncology people should tell them, or the chemotherapy people should tell them, or most importantly the palliative care person should tell them. So these are the reasons why staff differ to break the bad news. At the family's end, family is in denial. This is most important. There may be previous bad experience of breaking a bad news. May not be, they does not know how to break a bad news. They may fear that the patient may attempt suicide, or there may be some conflict in the family. Some family members want to tell, some may not want to tell. So they are undecided. There may be thing family is unable to cope with their own grief, so they are not able to tell the patient. They think that the patient will deteriorate faster or may lose hope. So these are the reason at the family's end. There are some environmental and skills and training factors, like cultural issues, medical legal issues, administrative support is not there. There are fear of complaints, like they are telling very badly, or they are telling outrightly, they are rude in behavior. Family people may these kind of they may pose these kind of allegations. So and there are some factors at the patient, and also like patient is not able to accept the diagnosis. He does not want to know that okay, it's okay, whatever the diagnosis is, okay, keep on going. He may not want to lose hope, and maybe that the patient has not autonomy to make the decisions, and there are many causes. So we have to keep in mind each and every cause, and then work upon it, and reveal the diagnosis to the patient and the family. Thank you.
Anybody would like to? Dr. Meena? Dr. Meena?
Yes, ma'am. Yes.
Any questions?
That was very well done, Dr. Mohammed. I think many of us identify with a lot of that. And if you actually go into that case, there are so many issues that can come out. It's a case that can be really discussed to depth. It's very nicely done, and your fishbone also was really good. And from the youngsters, like what Dr. Sunil said, all of you who are in, how many of you identify with it? How many of you feel that this is routine? And what would you do in situations like this?
So what's the first step in managing collusion? So some relatives comes to you and tells you that okay, we know all about the disease and prognosis, and you please don't tell it to the patient. What will be your approach to that caregiver?
So in the last class, we discussed that if we are very, if we aggravate the relatives, they might take the patient and leave. So we can't be too aggressive when it comes to, so that way the patient will probably lose care as well. So the only way is probably to convince the relatives that it's necessary without scaring them away.
So I think we must call for a family meeting like we did in this case, and a family meeting helps a lot. We make the whole family sit together and decide the further care plan. And in that care plan, we include the breaking the bad news or breaking the collision also. So we counsel them that what is the state of the disease, what problems they are going to encounter in future, and how it will help if the patient exactly knows about his condition, his or her condition. Because if the patient knows very well about his disease condition or status, then it will be easier for the patient to tackle it, to explain his or her problems to the relatives and doctors, and to manage it appropriately. Like if the patient knows what is his disease, what is his physical status, how, so then he or she can adjust or manage his physical activities accordingly, his daily activities accordingly. So, and he will be more and more comfortable with this. Otherwise he will say, okay, this is just a tumor in my leg, why I should be bedridden, why it is not stopping to bleed, it is continuously bleeding, what is the problem, why, when it will stop bleeding. So but if the patient knows that okay, it is a malignant ulcer, it is going to bleed forever, and I have to manage it in such a way that it will cause least trouble, like least bleeding and least odor and pain, then it will be better for him also.
The first thing that you have to understand is why the family is bullish. Because the family want to protect the patient from who? From us. Because we are the people going to deliver the bad news to the patient. So it is because they love the patient. So we have to acknowledge that, because they are in severe anxiety that we are going to tell it to the patient. So first of all, uh, I think there will be many versions of managing pollution, but if I think the first step would be if the patient caregiver and we are in different codes, then from here we will be serving the patient caregiver will be returning the answer, so that we will be in different codes. But it should not be like that for managing the pollution. We should be in the same code. We should be sitting together in the same seat. So first of all, we should agree the caregiver that okay, we are not going to tell it without your permission. That will be the first step. So that will reduce the anxiety of the caregiver, as well as that will allow us. It will help us to talk to the caregiver more. So that then we can ask them why, why are you telling like this? What's your concern? So exploring why they don't want to tell it to the caregiver is the next step. Then they will come up with many concerns why you should not tell to the patient. So we should hear that and we should empathize with them. Then next we should ask them, or there are some points why should we break the bad news to the patient. So which Dr. Vidya already mentioned. So that we will tell them, okay, these are the things why we should break the bad news to them. And then ask them, what do you think now about communicating bad news to the patient? So sometimes the patient caregiver tell you that okay, we understand that why it is uh, necessary to communicate the bad news to them, but still we don't want to tell them, or they may tell that we want to discuss it with other family members. We will tell you next week. So these are the some common questions. I don't think that you will get the solution with one sitting, and it may take some time. So you don't set agenda for that meeting because the agenda may not fulfill. So what you have to understand is it will take time.
I think that is why integrating palliative care early into the disease is hugely important, because you gain trust of the patient very early. Like when we see patients coming to this stage, if we had already seen this patient, which is what usually happens at our center, we integrate pretty early. So when we manage pain from the beginning, along with all their chemotherapy regimens, surgery as it goes on, you've already built trust. And by then, in your communication, it has been conveyed that this is palliative chemotherapy, this is palliative surgery, there is no cure. So once the trust is being built, it becomes easier for the family to kind of, accept and take you in. But like what Dr. Sunil said, the first thing is to tell them, we will not do anything without your consent. In our Indian setting, it's extraordinarily important to do that, because otherwise the comfort to the patient gets denied. It's not taking away the patient, but the comfort to the patient getting denied. So that, and another very simple, I mean, it's not simple, but it's something that we do is, again, ask, tell, ask. Ask the patient. Tell me how you're feeling, what is happening. Very often, a young adult at this age knows most of it. So there is a huge amount of denial in that. So what the family feels that they don't know, he actually knows. So you can just demonstrate it to them, because you ask the patient, tell me, and he tells you, and they hear. These are ways which we can try and explore and get it out. But don't be in a big hurry that you have to break that collusion now. No, it will be slow. You have to give it time, and don't do it because you have to break it. Do what is important for the patient at that point of time. Because if the patient is towards the end of life bleeding profusely, the priority there is good symptom control and then breaking the collusion. So sometimes we have to prioritize.
So I have a question, ma'am. So, okay, is it necessary every time to break a bad news or collision? Can we hide it?
That's a very good question. Whether it's necessary to break collusion every time, because again, denial can be one thing which the patient. Suppose he says that this is how I want to be, and he is not. That is why it's important to ask the patient, what do you want to know? Do you have anything more to ask me? Is there any question in your mind? If he tells you no, then why would you want to break the collusion or add any more information at that point in time? So it's not mandatory that because this exists, you have to break it. It's like knife. You just don't have to break it every time. But you have to see the patient's interest and ask the patient. And if he tells you, because many a times there is a patient who will tell you, if he knows it is all right for me, I don't want to know more than this. You are not at that point, it's not compulsory to break that collusion and to break denial. I mean, Dr. Sunil, I'd like your
Yeah. Regarding the bad news, patients have the right to know, but it is not their duty to know. Patients have the right to know, but it is their duty to know about the. So all the patients, some patients may not want to know. So in that situation, usually don't communicate the bad news, but there will be some instances where you have to communicate the bad news because it may adversely affect the management, or sometimes some people they may not go for the curative treatment because they don't know about the diagnosis. So in such situation, we may have to actually communicate the bad news because it is for the betterment of the patient. And regarding collision also, just as like Dr. Vidya told, it is always not necessary to manage the collision because sometimes we are looking at the comfort of the patient. Sometimes the patient will be near end of life, and at that time, as we know that the collision should be managed. So thinking like that, we need not manage the collision while the patient is near end of life because it is not going to do any good for the patient. It will not make any good. So we are looking at what can we do better for the patient.
That's why ethics comes in really big. Always have that beneficence versus non-maleficence in your mind before taking any decision. I mean, that's what we go by, be it symptom control, be it communication. Remember, whatever that you do or say should do more good to the patient than harm. So if we carry that scale with us all along, I think that becomes a guiding path for anything that we do.
I think we will stop here. I would like to thank Dr. Vidya for taking this session and all those who participated in this. Thank you. Shall meet you next Tuesday.
Thank you, Dr. Sunil, and nice to see all the young patients in palliative care. Welcome you and do well. Thank you, Dr. Sunil.
Thank you. Bye.
Thank you, ma'am.
Bye.
Thank you, ma'am. Thank you, sir. Thank you, everybody.